When we think of an infection, we often think of something on the surface. But pneumonia? That's different. It's a full-on war happening deep inside our lungs, where the very air sacs we need to breathe become battlefields. In this explainer, we're going to track this fight, right from the first breach to the final outcome. So let's dive in.
To really get a grip on this, we're going to follow a case. So, picture this, a 50-year-old man. He's brought in, and he is fighting for every single breath. You can just see it. His body is at war. But with what? And more importantly, why is the enemy winning? We need to look at the clues.
Okay, every patient's body tells a story, and this one has some really clear pointers. For 3 days now, he's been dealing with a fever, a nasty cough, and dyspnea, which is just the clinical term for that awful feeling of not being able to get enough air. When the doctor listens to his chest, the sounds on his right side are muffled, they're weak, and the chest x-ray, it confirms it. There's a big white shadow and opacity right where you'd expect to see clear, black, air-filled lung. His blood work is practically shouting inflammation. His C-reactive protein is through the roof, and his white blood cell count shows a massive spike in neutrophils, the immune system's frontline infantry against bacteria. Right, here's how we're going to crack this case. First, we'll nail down what this invasion really is. Then, we'll look at the 2 major strategies the enemy uses to attack the lungs. After that, we'll zoom in on the 4 stages of the battle itself. And finally, we'll connect all the dots to see how a diagnosis is made and what the possible outcomes are. Okay, first up, defining the invasion. Think of the lungs as a heavily guarded fortress. They're designed to keep invaders out. So the big question is, how do bacteria manage to breach those defenses? So the textbook definition sounds a bit intense, but let's break it down, because it's actually the key to everything. Pneumonia is what happens when bacteria get past the defenses and invade the lung tissue itself, the parenchyma. This sets off all the body's alarms. The tiny air sacs, the alveoli, get flooded with inflammatory fluid and cells. This process is called consolidation, and that's a word you've got to remember. It just means the normally light, spongy lung tissue starts to become solid. Under normal circumstances, our lungs are remarkably clean, protected by this amazing 3-layered defense system. First, you've got nasal clearance. Sneezing and blowing your nose gets rid of the big stuff. Second is the tracheobronchial clearance, which is this incredible escalator of mucus and tiny hairs or cilia that are constantly sweeping junk up and out. And then, the last line of defense, way down deep in the alveoli, you have macrophages. These are big immune cells that literally eat any invaders that get that far. So here's the crucial point. Pneumonia isn't just about bacteria being present. It's about our defenses failing. Think about it. If the cough reflex is suppressed, maybe from anesthesia or even just too much alcohol, the main gate is left unguarded. If that cilia escalator gets damaged from something like smoking, invaders can just slide right on down. And if those macrophage soldiers are weakened or overwhelmed, well, the enemy can easily set up a base camp. So who are these invaders? Well, the most wanted list changes depending on where the person got infected. Out in the community, the #1 culprit is usually Streptococcus pneumoniae. But inside a hospital, you're up against tougher, more resistant bugs like Staphylococcus aureus or gram-negative bacteria like Enterobacteriaceae. Knowing who you're likely fighting is absolutely critical for choosing the right weapon, the right antibiotic. All right, on to our second section. Once the bacteria are in, they don't all fight the same way. They have different strategies. And this leads to 2 really distinct patterns of attack that you can actually see in the lung: lobar pneumonia versus bronchopneumonia. Now, this is where the strategy really differs. Lobar pneumonia is like a full frontal assault. It's an army that wants to conquer an entire territory, a whole lobe of the lung, and it spreads like wildfire from one air sac to the next through these little back channels called the pores of Kohn. Bronchopneumonia, on the other hand, is more like guerrilla warfare. It sets up these scattered, patchy areas of infection around the smaller airways, and it can pop up in multiple places, even on both sides of the lungs. And wow, these images just show that difference perfectly. Look at the left, that's lobar pneumonia. That entire section of lung, it looks solid, dense, and pale. That is consolidation, plain and simple. Now look at the right, that's bronchopneumonia. See all those little scattered yellowish patches? That's that patchy inflammation we were just talking about. 2 completely different battle plans, 2 different visual results. And this brings us right back to our patient. Remember that white shadow on his x-ray? It wasn't just a few spots. It blanketed his entire right lower lobe. That is the classic calling card. We now know what we're dealing with. It's not just pneumonia, it's lobar pneumonia. The battle is concentrated in one major territory.
So that leads us perfectly into Section 3, the 4 stages of battle. Now that we've identified the type of war, we can zoom right into our patient's lung and watch this fight unfold step by step.
The classic battle of lobar pneumonia plays out in 4 distinct stages. It kicks off with congestion in the first couple of days. Then it progresses to red hepatization, followed by gray hepatization, and then, hopefully, it all wraps up with resolution after about a week or so. This timeline is the classic way to understand how the pathology develops.
So, stage 1, congestion. On the macro level, the whole lobe of the lung just gets heavy, boggy, and really red. Why? Well, the body has sounded the alarm. The blood vessels have been thrown wide open, and they're pouring fluid, proteins, and the first wave of immune cells into the fight.
And if we grab a microscope and zoom in, this is what's going on. Those air sacs, the alveoli, which should be empty, are now completely filled with this soupy mix of protein-rich fluid, tons of bacteria, red blood cells that have leaked out, and those first responder immune cells, the neutrophils. Next up is red hepatization. Now the term hepatization just means liver-like, and that is exactly what happens to the lung tissue. It becomes firm, solid, and has this reddish-brown color. The alveoli are now just jam-packed with neutrophils, more red cells, and the sticky web of fibrin. Clinically, this is when you often hear about patients coughing up rust-colored sputum, and this is why. It's from all those red blood cells in the mix.
From there, we move into gray hepatization. The intense red color starts to fade to a grayish-brown because all those red blood cells are starting to break down. Then finally, if the body's winning the war, we get to resolution. This is the cleanup phase. Special enzymes come in to dissolve the fibrin mesh, and the macrophages, the cleanup crew, move in to gobble up all the debris, hopefully restoring the lung back to normal.
Okay, last section. Let's tie everything we've just learned about the pathology directly back to our patient's lab results and talk about the possible outcomes of this intense battle. This table just lays it all out so clearly. That super high neutrophil count, that's his bone marrow working overtime, cranking out soldiers to fight the bacteria. That sky-high CRP, that's a system-wide alert signal being sent out by the liver. And that big white opacity on the X-ray, well, now we know exactly what that is. It's the physical proof of consolidation. Those air sacs are so full of fluid and cells that X-rays can't pass through them anymore.
But, the battle doesn't always end with a perfect victory. Sometimes things go wrong. If the infection is really bad, it can actually kill lung tissue, leading to an abscess, a walled-off cavity filled with pus. If the fight spills over into the lining of the lungs, the pleural space, you can get something called empyema. And sometimes the cleanup process just fails. The gunk in the alveoli doesn't get cleared out, and instead, it turns into permanent fibrous scar tissue.
And that really brings us to the final and maybe most important question. As a future doctor or a current clinician, understanding these stages isn't just about passing an exam. Knowing whether your patient is in the congestion phase versus, say, the gray hepatization phase, or knowing if they're at high risk for developing an abscess, this knowledge directly impacts every decision you make, from which antibiotic you choose to how closely you monitor them to whether you need to order another X-ray. It's the essential bridge between understanding the pathology and actually caring for the patient.